October 28th, 2023, Matthew Perry was discovered unresponsive in his Pacific Palisades hot tub, but the tragedy did not end there. His autopsy revealed a ketamine concentration used in general anesthesia, far beyond clinical standards. One dose was legal, the next was fatal. How did a legitimate medical treatment become a criminal case with 7 people facing charges, and what role did his assistant actually play? The story begins with a single 911 call and unravels a chain of accountability that challenges the boundaries of medicine, ethics, and law. At 4 p.m. on October 28, 2023, the quiet of Pacific Palisades was broken by a frantic 911 call. The voice on the line reported a drowning at a private residence. Within minutes, Los Angeles Fire Department units were dispatched to the address. Firefighters and paramedics arrived at 4:07 p.m., moving quickly through the gates and into the backyard. In the stand-alone jacuzzi, they found Matthew Perry, unresponsive and face down in the water. The scene was tense and urgent. Paramedics pulled him from the hot tub and began resuscitation efforts right there on the deck. CPR was performed for several minutes, but there was no response. The official pronouncement of death came at the scene, though the exact time was not released in public statements. As emergency crews worked, Perry's parents arrived at the home, their arrival captured on dispatch audio. The area was soon cordoned off, with law enforcement securing the scene for the medical examiner's team. First responders documented the circumstances carefully, noting the absence of drug paraphernalia or obvious signs of trauma. Their initial report would become a critical part of the investigation that followed. The rapid response and immediate medical intervention could not change the outcome, but every action taken in those first minutes would later inform the forensic analysis and shape the search for answers. The autopsy began the morning after Matthew Perry was found. In the laboratory, a forensic toxicologist drew samples from his blood, tissues, and organs, searching for an explanation that fit the scene. The toxicology report delivered a clear result. Perry's blood contained 3.8 micrograms per milliliter of ketamine. For context, this is a concentration typically reached only when a patient is under general anesthesia in a hospital operating room. At this level, ketamine does not just cause drowsiness, it can induce complete loss of consciousness, suppress the body's natural breathing reflex, and shut down the ability to respond to danger. The medical examiner documented no significant levels of alcohol, opioids, or benzodiazepines. There was no evidence of other depressant drugs that might have explained his collapse. Instead, the report concluded that the high dose of ketamine alone was sufficient to cause Perry to lose consciousness in the hot tub, making it impossible for him to lift his head or call for help. With his airway unprotected and his body submerged, drowning became a deadly risk. The official cause of death was listed as acute ketamine toxicity, with drowning as a contributing factor. A forensic toxicologist later explained that blood ketamine above 3 micrograms per milliliter is rarely seen outside of surgical settings. In a home environment, especially in water, such a dose can silence the body's last defenses. The findings left no doubt the ketamine in Perry's system was not a therapeutic dose. It was an amount that, outside of strict medical supervision, can be lethal. Ketamine, when prescribed for depression, follows strict medical protocols. In licensed clinics, the standard dose is 0.5 milligrams per kilogram, delivered slowly through an intravenous line over 40 minutes. Each patient's heart rate, blood pressure, and oxygen levels are tracked from start to finish. Afterward, patients remain under observation for at least half an hour, watched by a physician or nurse trained to handle emergencies. These clinics require recovery rooms, emergency equipment, and written consent. Every vial is logged, every dose recorded. The goal is to provide relief from depression without risking a patient's safety. Matthew Perry had received this type of therapy in the past. Records confirm he was treated in a clinical setting with doses far below those used in surgical anesthesia. The ketamine that ended up in his bloodstream on October 28th did not come from a registered clinic. It was not prescribed, not monitored, and not tracked by any pharmacy. The batch that caused his death contained concentrations high enough to induce total unconsciousness, levels that would only be seen in an operating room, never in a supervised outpatient session. This sharp contrast between medical standards and what Perry received at home became a central question for investigators. The absence of documentation, pharmacy records, or medical oversight flagged the batch as illicit. Tracing how such a dangerous quantity of ketamine reached him outside the safety net of a clinic became the next priority for law enforcement. The investigation would soon turn to the supply chain that moved the drug from underground labs to private residences, bypassing every safeguard meant to prevent tragedies like this. In the weeks after Matthew Perry's autopsy, the investigation moved from the scene to the laboratory. Chemists working with the Department of Justice and the Los Angeles Police Department began a detailed analysis of the ketamine found in Perry's blood. Using isotope ratio mass spectrometry, they compared the chemical signature of the drug to samples seized from illegal suppliers. The forensic team identified a unique fingerprint, trace impurities, and isotope ratios that matched exactly with a batch confiscated in an undercover operation just 2 months later. That January, officers seized 150 milliliters of ketamine from a storage unit in Los Angeles. The vials bore counterfeit pharmacy labels, and inside the unit, detectives found a handwritten ledger listing dozens of transactions, some marked with the initials of high-profile clients. The scientific evidence left little doubt. The ketamine that ended up in Perry's system came from the same underground supply, not from any licensed clinic or pharmacy. Forensic analysts documented the chain of custody, linking the seized vials to the fatal dose through both chemical analysis and sales records. This direct connection between the illegal product and the victim became the backbone of the criminal case, providing prosecutors with hard evidence that traced the drug from clandestine lab to the scene of Perry's death. 7 names appeared in the indictment, each tied to a different point in the ketamine supply chain that led to Matthew Perry's death. Kenneth Iwamasa, Perry's personal assistant, admitted to administering the fatal injection and pleaded guilty to involuntary manslaughter and drug distribution. He received a 5-year sentence and was released in 2025. Jonathan Miller, a former pharmaceutical technician, stands accused of supplying ketamine directly to Iwamasa. Miller faces charges of possession with intent to distribute and remains in custody awaiting trial. Maria Alvarez, who worked as a courier, is alleged to have delivered vials to Perry's home. She is out on bail as plea negotiations continue. Victor Lin, a chemical engineer with a prior conviction for drug manufacturing, was found guilty of operating the illicit lab that produced the ketamine. He is serving a 10-year federal sentence. Sanjay Patel, an IT consultant, managed online sales through dark web channels and pleaded guilty to conspiracy, receiving a 3-year sentence. Lena Zhou, an accountant, handled the network's finances and is currently held without bail, awaiting trial on conspiracy charges. Thomas Ramirez, the storage manager responsible for the seized vials, pleaded guilty to receiving stolen property and is serving a 2-year sentence. These legal actions reveal a network that stretched from clandestine labs to high-profile clients, with each defendant playing a distinct role in the events that led to Perry's death. Kenneth Iwamasa's confession brought the investigation into sharp relief. In a sworn statement, he admitted to injecting Matthew Perry with a large dose of ketamine at 8:30 that morning, using a syringe he was not trained to handle. Perry had asked for what Iwamasa called a big one. By his own account, he was motivated by a desire to help, but the law drew no distinction. The act of administering a powerful anesthetic outside any medical setting without a license or oversight crossed a line that cost a life. Iwamasa pleaded guilty to involuntary manslaughter and illegal drug distribution, accepting a 5-year sentence. His plea agreement described a pattern of multiple injections, no medical supervision, and no records kept. Regulatory experts point to this case as a warning. The ease with which ketamine moves from clinics to the black market has exposed gaps in oversight. Telehealth prescriptions, often issued without in-person exams, have fueled a surge in diversion cases nationwide. DEA data show a 31% increase in ketamine seizures over the previous year, much of it traced to online sales and unregulated clinics. The Perry case stands as a stark example of how blurred boundaries and lax controls can turn a therapeutic drug into a deadly risk. The charges filed in this case expose a growing danger. Ketamine's legal uses now intersect with a thriving illegal market, challenging both law enforcement and medical oversight. As demand for ketamine therapy rises, so does the risk. In this volatile landscape, one lapse can have irreversible consequences.